they come together. These nasal pits, they are the future nares, that is the anterior nasal cavities, nasal pits. Okay, this is the frontonasal prominence. This is the maxillary process. This is the mandibular process. Okay, prominences. So during the development, these two things fuse, and then along the nose and the maxillary process come medially, and then both the things, and then between the mandibular process, then the maxillary process, there is a stomatodium will form, and then between these they fuse together and then form the primitive palate. As these close together, and then along with the all the mesenchymal and then epithelial tissues, they migrate and then they fuse together and then form. Between the lateral nasal pit, lateral nasal process and the maxillary, there is a groove is there. That is the nasolacrimal groove. The future nasolacrimal groove will fuse together and then form as a nasolacrimal duct, from where it is the tears will be drained into the nasal cavity. Okay, so this invagination of the nasal pits will form, and then this is going to become the nasal cavities. So I understood.
Yes, sir.
Okay, so you see, as the embryo advances, this is a the mandibular process, this is the maxillary process. These maxillary process all together, they fuse together and then for the philtrum, and then there is the midline. This is the ala of the nose. This is the medial crust, and then this is the frontal process, and then maxillary process, frontonasal process of the maxilla. This maxilla coming together, you see, and then this is becoming a mandible, and then this is the stomatodium, that is the oral cavity. Okay, and then here this nasolacrimal for the pit will close together, and then from the eyes it will drain directly into the inferior meatus, forming a nasolacrimal duct. That is the tear system. Okay, this is the, you understood? Hello. Okay, so during the formation of the skull base, that is the skull base. So the skull base is dividing the intracranium into the nasal cavity. So these mesenchymal structures are formed in various several centers, because there are so many bones. Ethmoids are there, sphenoid is there. Like that, there are so many things are there to form the skull base, that is dividing the nasal cavity and the nasopharynx from the intracranium. So these are the various centers are there which will eventually fuse and ossify. So before that fusion, there is a recognized spaces which are there, which we have to know. So developmentally, these spaces will fuse in a lateral line, and any congenital midline nasal masses usually will come through this identified recognized spaces. What are those spaces? That is fonticulus nasofrontalis, this is prenasal space, and foramen cecum. These are the three spaces which are recognized before fusion, before the complete fusion of the mesenchymal tissue of the base skull, forming to ossification and then becoming into, in the beginning there will be separate like all the skull bones. Okay, and then here you see, here between the frontal bone and the nasal bone there is a fonticulus nasofrontalis. This is a, unless before fusion there will be a potential spaces there, and then there is a foramen cecum which is there separating the skull base and the nasal cavity here. That is the maxillary process. Between the maxillary process, before they fuse, between the medial nasal pits and everything fuse, there is another thing is foramen cecum in the midline, and then other thing is prenasal space. Prenasal space is between the nasal pyramid, that is the nasal bones, and this one is a future septum, that is known as capsule. That is the between the internal structures. That is the between the frontal and nasal bones. This is the one prenasal space between the nasal bones and the nasal capsule. This is the nasal capsule. This is the nasal capsule. Nasal bone. This is the prenasal. Nasal capsule is the future septum. Okay. So these are the three potential spaces. So this is the meninges and the brain. Okay. So it may come through this foramen frontalis nasofrontalis, or through the foramen cecum into the nasal cavity, and then through the prenasal space into the beyond the nasal cavity, and then or into the by the side of the septum into the nasal cavity also it will come. Okay. So now coming to the nasal dermoid. A nasal dermoid is either a cyst or a sinus. A sinus with a discharging sinus with a tuft of hair. Usually it will be there in the either in the midline or a pyramid in position of the nose. This is the most common congenital midline mass. 1 to 3% of all the dermoids of the thing, and then 3 to 12 dermoids of head and neck. 3 to 12% of the dermoids occur from the nasal dermoid on. Okay. What is the development of the dermoid cyst? So during the development, projection of usually during the development, the projection of the dura through the foramen cecum and attaches to the skin. You see, here the dura will come and attach to the skin, and then during development, the dural with the skin get detached, and then it will retract and then go into the nasal intracranial. Suppose if there is a persistent thing is there along with the thing, or sometimes these dural matter along with the epithelium is entrapped here. Afterwards, the foramen cecum as well as the frontalis nasofrontalis, either this route or this route, again any route it will come, and then it can get entrapped with which is having a both mesenchymal as well as epidermal structures are there. So it will contain all the dermoids. The congenital dermoid usually they contain both epithelial as well as mesenchymal contents. So what are the various mesenchymal contents? That is the hair follicles, epithelium, and then sometimes cartilaginous, or sometimes there will be a bone also can develop. Okay. So dermoid, it can be ectodermal and mesodermal also. It can be a midline or paramedian, or just like a sinus with a black heads. That is the black hair also. You can see tuft of hair coming out of the thing. Midline nasal pit fistula or infected mass from glabella to. So it is from the glabella to columella. It can occur anywhere between the glabella and columella. Okay. Sometimes it can be a single cutaneous tract with hair at the opening. May secrete pus or sebum, because it is lined with the skin and everything. It can be lined with a sebum also. Okay. That is the dermoid. So what will happen usually if they are open or anything? So there will be intermittent inflammations can occur. They can get infected. They can become infected dermoids or abscess formation within the congenital dermoid. And then underlying bone necrosis causing osteomyelitis of the surrounding bone. And then broadening of the nasal root. And then if it is having a still contacts with the intracranium, can lead to meningitis. Then cerebral abscess or extradural abscess, or there are brain abscess. It can occur anything. It can lead to any of the complications. So, which we have to go for surgery. Surgery is the only option for pain. And then, so the central nervous connectivity variable reported from 4 to 45%. So you see, this much of variability is there. These dermoids can have a intracranial connections from 4 to 45%. What are all these? So these are all the various things which are associated with other congenital abnormalities. What are the other congenital abnormalities? Just like oral atresia, mental retardation, spinal cord abnormalities. Hello? Hydrocephalus, hypertelorism, hemifacial microsomia, albinism, corpus callosum agenesis, cerebral atrophy, lumbar lipomas, cyst of the frontal lobe, coronary artery abnormalities, cleft lips and cleft palates, and tracheoesophageal anomalies, then cardiac and genital and cerebral anomalies. These are all the various anomalies which a person with a dermoid can have. So one has to understand that. Then we have to exclude each and everything before proceeding for. Coming to the gliomas. What is the glial tissue? What is the glial tissue? Glial tissue is a connective tissue within the brain. Okay, they are the CNS supporting good. Muhammad Husseini. What is that? Muhammad Husseini. Who is that? 103. Okay. CNS, central nervous system. So this is meninges and the brain tissue also comes out. Then afterwards it gets to, that means all the opening. Yes, and then there is this glial tissue is entrapped outside your intracranium. They will become a gliomas. So it can be a red or bluish lump, either in the external nose or in the intranasal cavity, from glabella, maxillary suture, or intranasally, or it can be usually it is non-compressible and firm. So the difference between dermoid is soft, cystic, whereas it is firm in consistency, and then it is non-reducible. Sometimes dermoids, their intracranial connectivity, they can be compressible. So these gliomas will never fluctuate while the child cries. So whenever a child cries, what will happen? The intracranial pressure will increase, and then there will be a and then there is a tensing of the, and then whenever the patient is, will be, there is no, because it is transillumination, unlike in meningoencephalocele, where they are filled with CSF. Yeah, and then these can have a vascularities like a telangiectasis. That is a abnormal vasculature over that. So these are the dermoids. A dermoid can be intranasal also. Here also the dermoid, the intracranium, through the foramen cecum, through the connectivity to the dura, but it is closed. So development of extracranial rest of glial tissue, abnormal closure of the frontalis, frontalis, possibly. So these are the possibilities of encephaloceles which have lost CSF connectivity. They are originally encephaloceles, but because of the fusion and then lost continuity with the intracranium and the CSF, they will become completely solidified, and then they are very firm. Okay. So it can be like this, or it can be a intranasal, a pinkish or bluish pink color. So gliomas can be extranasal around 60%, intranasal can be 30%, both intra and extra nasal can be 10%. Dural connectivity is having a 35% of the intranasal cavity, intranasal dermoids are having dural connections, whereas extranasal only 9% are having. These are all statistics. Okay, overall 15% dural connections will be there. So here the percentage of CSF rhinorrhea and meningitis possibilities are there, but very less. Because whenever there is a dural connectivity is there, then there is every chance of having a intracranial, that is infections like meningitis. Or if you take a biopsy, then if they are having intracranial connectivity, you can have a CSF leak. Coming to the encephalocele. So encephaloceles are that is the extracranial herniation of the meninges with or without brain tissue. So this is if there is only meninges are there, they are called meningoceles. Otherwise, they are known as meningoencephaloceles. If there is a brain tissue along the meninges are there, usually they are meningoencephaloceles. Okay, is very rare, and then you should have a subarachnoid connections will be there here, and then in 1:35,000 bucks, in 1 in every 35,000 they are there. But in Southeast Asia and Russia, the incidence is somewhat more, that is 1:6,000. 30 to 40% of the associated anomalies will be there, that like microcephaly, hydrocephalus, microophthalmia, anophthalmia, diseases of the corpus callosum, prosencephaly, cortical atrophy, and ventricular dilatation. These are all the various CNS abnormalities with encephaloceles. So this is also that the developmental anomaly, abnormality is the same thing, but depending upon the contents, this is either it could be encephalocele, meningoencephalocele, or only meningocele, or it is a dermoid, or it could be a glioma. Okay, so the pathophysiology is the same because of the closure defects. So what are the various encephaloceles? So usually bluish, soft, compressible, transilluminating, and then pulsatile. Whenever the child cries, they grow, they enlarge, and then they are pulsatile. Because of the vascularity of the meninges, there will be vascularity will be there. And then they enlarge and cry. And then positive Furstenberg test. What is the Furstenberg test? When you compress both the jugular veins, sentinel jugulars, there will be enlargement of the structure. That is, because of the decreased venous return, there will be increased intracranial pressure, and then there will be an increase in the size of the swelling. That is known as positive Furstenberg test, which is a mnemonic, and that's the diagnostic of that is the intracranial, that is the meningoencephalocele or meningocele. Okay, so they originate medially in the nose, cannot cause probably medially. So usually they are midline and then come close to the septum. So whenever you are examining, if they are intranasal, then they can be both intranasal as well as external also can be there. If at all, if they are intranasal, you cannot pass a probe medial to the mass because they are very much close to the septum. You can pass a probe laterally, but you cannot pass the probe medially. Okay, whereas gliomas become, because they come usually down and then they will be organized separately, so you can pass both the sides. Usually can be originate laterally also. Sometimes you can not pass probe laterally for the gliomas, whereas in meningiomas you cannot pass probe medially. So these are all usually associated with CSF leaks, because sometimes somewhere there is a pressure changes will be there, infection will be there, meningitis, CSF rhinorias, all are very, very common. So encephalocele, they can be divided into three types depending upon their origin, site of origin. It can be occipital. That means most common type is occipital. That is the back of the head, usually 75%. Sinciput, that is in the front of the head, that is, and then basal, that is into the nasal cavity or into the nasopharynx. They are known as basal. Sinciput, there is coming, both occipital and sincipital are usually they are externally coming encephalocele, and then whereas basal means they will be into the nasal cavity or into the nasopharynx. Occipital anterior frontal, so that is sincipital ways anterior, or they are otherwise known as frontal. They can appear at the dorsum of the nose, or be immediately to the orbit, or in the forehead. Basal is usually intranasal, nasopharynx, or posterior to the orbit, because they herniate through the cribriform plate or posterior to it. So if they are herniating through the hole, that is a defect in the cribriform plate, they present in the nasal cavity. If they go posterior, and then they may go into the nasopharynx, and then potentially they cause a nasal obstruction, and then cause airway obstruction to the neonates. So it could be a nasofrontal, nasoethmoidal, or nasoorbital. This sincipital can be nasofrontal, it can come anteriorly. Nasoethmoidal, between the nas and the ethmoid, and then present into the thing, and then nasoorbital, coming to the orbit itself. Okay, these are all the various types of sincipital encephaloceles. So basal encephalocele, because we are concerned as an ENT surgeon, and then we are concerned with the only sincipital, and then that is the basal. So we see they present with the either external mass or in the mass occupying lesion in the nasal cavity. Transethmoidal through the cribriform plate into the middle meatus, or sphenoethmoidal extends through the cranial defect between the posterior ethmoids and sphenoid to the nasopharynx. Transsphenoidal presents in the nasopharynx. Sphenomaxillary through the superior and inferior orbital fissures into the sphenomaxillary fossa, and then onto the side of the posterior to the orbit, compressing the orbital apex and everything. So how do you evaluate the nasal mass? So whatever all the masses, either make it a dermoid or a glioma or the encephalocele or meningoencephalocele, how to do? First of all, what you have to do is physical examination. Take careful exam whether they are from the birth or immediately at the early years of the life, whether they are appearing or not. Usually the congenital, there is a, that is a rule of 7. Within all the congenital abnormalities will occur before 7 years. Okay? And then they present with a history of nasal obstruction, a polypoidal nasal masses. So one has to be very careful. So a mass in the nasal mass, one has to. So can you have a nasal polyps in the early in the which nasal type of polyps you will find below 4 years, before 4 years? Can anybody? Which is having a sodium depletion in the sweat. Along with that, what congenital condition which will have a low sodium in the sweat? Anyone? Yes, cystic fibrosis. Good, very good. So cystic fibrosis will have this type of multiple polyps in the nose. Okay, so one should be very, very careful. You should have a differential diagnosis. Whenever you are seeing a fluctuating soft mass is there, but the polyps will not be fluctuant or Furstenberg test will not be positive. Whereas here in these encephaloceles, usually it is positive. Okay. So CSF leak will be there, presence of hair or fistulous tract. So whenever you see a fistulous tract and then hair, you have to see. Usually they will be external. They are dermoids, which are compressible. Sometimes all the encephaloceles are compressible. Some of the dermoids are compressible, depending upon the intracranial connectivity. And then pulsations, they are most commonly with the encephalocele. Enlargement with the crying, and then enlargement with the internal jugular compression. They are tegnomonic of that is encephaloceles. So what is the thing is always you have to evaluate radiologically. Yeah? That is CT and MRI with a contrast. So whether dermoids and usually dermoids and gliomas, there will not be any intracranial extensions. So whether if they are intracranial extensions, very rarely dermoids will have, but almost all the encephaloceles and then meningoceles will have intracranial connectivity. So you can establish by doing your radiological evaluation. So usually these children, dermoids will have a fistulous tract, hair, pus or sebum or midline. Glomerulus form, non-compressible, does not transiminate, and then there will be telangiectasias. Encephaloceles are soft, compressible, bluish or red, enlarged with crying, and then positive Furstenberg test. So never, do not biopsy extra intranasal mass in child before taking an imaging. So because of risk of meningitis or CSF leak, so one should not attempt any biopsies. Okay. So what is the radiological evaluation? CT and MRI most used. CT findings include fluid filled cyst, or is a soft tissue mass or intracranial mass with the connectivity, enlargement of the foramen cecum, that is a bony defect you can see there, distortion of the crista galli. Crista galli, what is crista galli? Anyone? Crista galli. What is the crista galli? Is a part and parcel of what structure? Hello? Yes, that is the intracranial extension of the ethmoid, the crista galli. Good. Shyama Mandinya. Good. Okay. So it is a, and then Pranavi, Bocha, both. And then another thing is somebody else has told that is a ethmoid, bone, ethmoid, upper part of the nuclear fluid of the ethmoid. Okay, so all of you, good. So crista galli, suggestive of intracranial extension and enlargement of the foramen cecum and the bifidity of the crista galli. Sometimes it can be abnormally thin or bifid crista galli also can be there. These findings are only valuable if absent. Okay, these findings are only valuable if absent. When present, may be false positive also. So if they are absent, one has to be very careful. If they are present, sometimes you have to see once again. Okay. So this is the thing. Nasal dermoid exists within the dermoid anterior to the nasal and maxillary bones. These are the here encephalocele. There is a defect in the skull base, cribriform plate, and herniation of the brain tissue into the nasal cavity. That is the CT imaging. So bone windows are better visualized with CT, whereas soft tissues and all we can do it with a MRI. So if you take an MRI, nasal dermoid will have a very, this is the MRI imaging. And then So if you take a sagittal T1 sections, you see, and then T2, you can see the hyperintense. Okay, that means it is a filled with the CSF. Okay, so coronal gliomas. So it doesn't have any intracranial connectivity. Glioma is a having very much intense hyperintense, is a variable intensity is there. This is also encephalocele, which is having a connectivity. These are all. And then what is the, after your confirmation of the diagnosis, the treatment is surgical excision. Always a surgical excision is a very complicated one. Is a complex. Always it, because it depends upon the what is the extent, and then whether they are in connectivity with the intracranium or not. If they are not connected to the intracranium, yes, the as a plastic as well as the ENT, and then craniofacial surgeons, they can do and then open the dermoids and everything we can operate upon, and then do it externally, as well as if they are very much nasal, in the endonasal, we can do an endoscopic approach also. We can remove all the encephaloceles when with a mild small defect. Sometimes encephalocele also will project. We can cauterize and then we can excise the encephalocele, and then the skull base defect can be closed with the endoscopically also. This is a complex surgeries are there. If depending upon the what is the defect which is there in the skull base, if the skull base defect is very large, then you cannot do it under with the endoscopy thing. Only a neurosurgical intervention also needed. So if it is causing external deformity of the nose by flaying the nasal bones and then causing a very flat nose and any bony atrophy and osteomyelitis and everything, after excision, one has to do a second stage reconstructive surgery by a plastic surgeon or a facial-maxillary reconstructive surgeon. So all the dermoids and all the gliomas must excise in entirety. Otherwise, they will recur. So always you have to establish whether they are having. So by splitting the bone and everything, you have to split open the nasal bones, and then you have to go up to the foramen cecum. And then completely the tract has to be excised. Otherwise, they will recur. Recurrence is very common if the excision is incomplete. So these dermoids can be endoscopically also. Transverse rhinotomy has been discussed because to avoid any vertical scare and then splaying of the nasal bones, there is a transverse rhinotomy. Transverse means all across the nose. You have to cut open and then open the nose. You have to open the above up to foramen cecum. Then again they have to be sutured, and then or plating has to be done, and then it has to be corrected. Dermoids with intracranial extension without craniotomy, one has to nasal bones removed along with the anterior part of the frontal bone, followed sacs with the cribriform plate, that is the intracranial extension. One has to, a neurosurgeon has to come into action. Then along with the neurosurgery and plastic surgery, they can both can remove and then they can reconstruct the entire nose and everything after repair of the thing. So the gliomas, only intranasal gliomas, you can do it by doing it via open or endoscopically. Endoscopically, when if they are amenable, endoscopically we can completely remove with a nasal endoscope. Or if they are very large enough and then you don't have any space to go in, yes, a lateral rhinotomy approach. You can go into the nasal cavity. Then a most lateral rhinotomy operation has to be performed. So a encephalocele, because they will have a mainly large defects within the skull base, usually it's a combined approach with a neurosurgeon. A frontal craniotomy is performed, intracranial mass is excised, bone dura defects are repaired, and then extracranial mass is then removed. Mortality in this intracranial the neurosurgical procedures is around 46%. And then if it is a small one with a intracranial meningeal, we can do, as an ENT surgeon, endoscopic surgeons, we can do the endoscopic excision of the frontal, that is the intranasal encephalocele. So in conclusion, midline masses are rare but must be remembered in the differential diagnostics. And then always do a Furstenberg test to exclude, that is whether it is a, what is it? If it is a Furstenberg, it is positive. What do you suspect? What is Furstenberg test? Oh, so one thing is to exclude encephalocele. Yes. What is that? What is this test? You are correct. Encephalocele one has to be suspected. So compression of both the internal jugular veins will result in increase of the swelling because of the decreased venous pressure, venous outflow. That is the Furstenberg test. Okay, good. And don't biopsy without imaging. This is a dictum. Don't biopsy of the a congenital mass in the midline mass of the nose or the external or internal without any imaging. Surgical intervention is the only option. Okay. The next abnormalities can be because of the fusion defects. It can be a cleft nose. Apart from the midline swellings, what are the things? The clefts in the nose. It can be a partial cleft. We call it a bifid nose. Some people will be having a midline groove with a like just two noses. There is a bifid nose. Or sometimes complete absence of the nose because failure of the fusion of the medial nasal placards. So result in erainia. That means no nose at all. Only two pits, two holes will be there. So these are all corrected by a rhinoplasty procedures, a corrective procedures. So any abnormalities of the nasal pyramid can occur developmentally. It can be a nas flatal breach along with the cleft lip, palate or cleft lip, or wide nasal bridge, upturned nose, or deviation of the nasal septums. 99% of the individuals will be having a deviated nasal septum, or notched or hypoplastic alas, or small nares, very compressed nasal nares, or upturned nares. Sometimes this is a pugnose deformities. That means if you lift your tip up, how it will appear. So that is the nares, nasal nares will not be seen frontally. Our nares, anterior nasal cavity, anterior nares will be looking down. If they are seen anteriorly, that means upturned nares or anteverted nares. And then short or long columella, very, very short columella, resulting in very depression of the nasal tip, or very long columella, resulting in show. That means abnormalities will be there. And then projecting the tip very, if the column is very large and then everything, what will happen? The nose will come forward and then it will be abnormally projected tip. So abnormalities can be flat nip associated with the cleft lip and palate. Saddle nose involves the bones and cartilage, both can be there. A saddle nose can be a congenital or also acquired. So it is there in a syphilitic patients, and then also in lepromatous patients. There will be saddling of the nose, and some other chronic granulomatous disease of the nose also you can have a saddle nose. Hump is also a congenital problem. Hump for a male is a masculine, whereas hump for a female is not so aesthetic. So most of the people with the hump, the females, will come for surgery, remove the hump removals. Whereas males, hump is a masculine feature. So they don't usually consult for us for any correction of the nose, unless otherwise it is very abnormal. So these are all the things can be corrected by rhinoplasty procedures. There are various rhinoplasty procedures are there. We can do it and then we can correct them. And then next is the atresia of the nasal cavities. Atresia can happen either to the anterior nares or the posterior nares. Posterior nares is otherwise known as choanal. So if the posterior nares is atretic, we call it as choanal atresia. If the anterior nares is atretic, it is the stenosis. Anterior atresia. Stenosis is usually an acquired thing because of chronic trauma, a chronic infection, or a trauma. That is stenosis. Whereas atresia means is a developmental abnormality. That means the bone, that is the vestibular aperture, is atretic. That means very, very narrow. What is when do you say it is narrow? If it is a newborn child, if the transverse, the vertical aspect, anterior-posterior thing is normal, but lateral, side-to-side nares, if it is less than 10, 11 millimeters, then it is a atretic. We call it as a symptomatic atresia. Okay, if still completely, sometimes it may not be canalized also, completely atretic. So if one side is atretic, the child is survives. Otherwise, child will have a signs of immediate birth. The child cannot take breath through the nares because of the atresia. So this condition, the child will be cyanotic. Alternative cyanosis with the crying and everything. Again, because with the crying, they will take the breath through the oral cavity. They will become normal. Again, usually we are all obligatory nasal breathers. We are not a oral breathers. We try to breathe through the nose only. Whenever there is any obstruction in the nose only, we try to open the mouth. So always, whenever anybody is opening the mouth and then taking breath, means one has to understand that there is an obstruction to the nasal cavity. So, okay. So atresia there. So you see the atretic anterior. There is no canalization. There's a mesenchymal overgrowth and then calcification, and then there is a nasal anterior nares is somewhat very, very closed. In fact, easily mistaken for because anteriorly you can see normally, but here it is the bony atresia. So anteriorly nares will be appearing normally, but unless otherwise seen in particular, we cannot identify the answer. So these are all the cases which are being mistaken for choanal atresia. This is the choanal atresia means atretic place will be taking this place. Okay. So CT it is showing that 11 millimeters in terms of influence is considered as a diagnostic. Okay. So what is the thing? Milder forms can be treated conservatively by humidification, tropical decongestion, and suctioning, because there will be secretions, pent-up secretions will be there. But always it's better to go for a widening of the anterior nares by sublabial approach, because the sublabially you can approach and then elevate, and then you can drill the atretic bone and then you can open up the thing. This is the transnasal. It will be difficult in the child. Only sublabial approach you can do it better. Now coming to the choanal atresia. Choanal atresia is one of the important things for you. It is usually occurs 1 in 5,000 to 8,000 births. It is a congenital condition. Usually, sometimes majority of the choanal atresia is congenital. Very rarely it can be acquired because of the certain diseases where chronic granulomatous diseases we have seen certain conditions where completely the choana is closed. That means oral cavity along with the nasopharynx completely will be stenosed. That is a stenosis. Okay, this atresia is usually congenital. So what is this thing is embryologically, while canalization from anterior to thumb, the bucconasal membrane will be disappearing, as the age proceeds. It can be, if that is the bucconasal membrane, persistence of the bucconasal membrane, the primitive bucconasal membrane, there's a persistence, will give rise to the choanal atresia. It can be unilateral or bilateral. So unilateral is twice as common as bilateral, or is usually it is common with female children. It can be a complete or incomplete. That's a partial or complete. So it can be a membranous or bony. 95% to 90% of the choanal atresias are bony. Only 10% are membranous. Okay. The typical presentation unilaterally, usually they present very late. Okay, they come with a unilateral nasal discharge, which is a tenacious but without any air bubbles. While as bilateral, patient will have a emergency. Newborn is a neonatal emergency. It can be a cyclical cyanosis relieved by crying. Always, because whenever there is a patient is crying, they will take the breath through the oral cavity. Common in females, unilateral is common. Undergoing for a long time, nasal obstruction, persistent of nasal discharge, inability to pass catheter through nasal cavity. If you do a diagnostic nasal endoscopy, you can find it out. So bilateral is seen in newborns, is a neonatal emergency. The respiratory obstruction, putting up an airway, gives a life. That is a McGurvin's nipple is there. There is with a wide opening into thing. The patient can feed as well as take a respiration through the oral cavity. And then putting a few drops of dye in the nose and then examining the oropharynx. You will not get any dye into the oropharynx. The diagnosis is only by inability to pass the nasal cavity into the oropharynx, installation of radiopaque substance, and then taking an X-ray. You can see obstruction there, CT imaging of the studies, and nasal endoscopy. These are the diagnostic tools. So what you do, if you do a diagnostic nasal endoscopy, you see here complete. There is no opening. It will not go into the nasopharynx. It is stops there. It can be a or a bony. Only CT or radiological investigation will tell us whether it is a bony or membranous. Usually, 90% of the things are bony. Sometimes are okay. What are the boundaries of the atretic plate? Superiorly, the sphenoid. Laterally, the middle pterygoid plates. Medially is the vomer, and inferiorly horizontal portion of the palatal bone. These are the boundaries of the atretic plate, where you have to drill it out. So this is the embryology I have told you. And then treatment depends upon whether it is a unilateral, bilateral. Unilateral, you can always wait for some time, allow the child to grow, and then you can do to prevent any restenosis. And then bilateral atresia, it is always an emergency. First, secure an airway either by doing a tracheostomy or by intubation, or McGovern's nipple placed in the mouth give rise to, can be breathe and feed, intubation and tracheostomy, and then treat. It can be surgical approaches, can be transnasal, transseptal, transnasal endoscopic approach, transpalatal approach, and laser therapy. Laser boring also you can do. Transnasal, because nowadays with a transnasal only endoscopic approach, we could able to completely remove that and drill the atretic plate, and then we can establish the connectivity between the nasopharynx and the nasal cavity. These are all the various approaches. Everything. This is a transnasal transeptal approach. And then this is a transnasal endoscopic drilling, and then we can establish an endoscopic approach. And then transpalatal approach, you can go transpalatal, Wilson's transpalatal incision, and then you can establish by atretic plate. You have to drill it and then remove that, and then you can take it out. Patient placed in position and retained for minimum period of 6 weeks. The stent has to be there, and then application of topical mitomycin can help for again restenosis, prevent restenosis by applying a topical mitomycin C, which is anti-cancerous drugs. So 2/3 of cases may be associated with other congenital abnormalities, usually with a bilateral ectasia, that is a charge syndrome or a teacher's colon syndrome and Crouzon syndrome. What is charge? Charge is nothing but coloboma of the iris, heart malformations, atresia of the choana, and then retardation of the growth, genital hypoplasia, ear malformation along with the deafness. Usually congenital, that is a sensory neural deafness, or both. And then teacher's colon is a malar hypoplasia, colobomas, medial two-third lashes without lashes, the medial third of the eyebrows, retrusion of the skin, that is a chin retrusion, malocclusion will be there. Actually, malformity is a low set ears or a microchias, and then patient will be having a sensory neural hearing loss. Thank you. Thank you, Gamma. Okay.
Next class.